So in my welcome, I mentioned a little bit of the forest and the trees. So I guess we're going to start with this section of your agenda. We are going to start with the forest and end with the trees. So throughout, I think this section of your agenda says PPS overview. You're like, what are we going to do by way of overview? Well, in this section, I want to provide you with some context for understanding how DSRIP fits in the New York State Health agenda. I'm also going to give you some information. I'm just about to set my paper. I also want to give you some information on some state level developments in DSRIP. So I've got a set of pointed slides on some specific pieces of information that I know people are looking for. And I'm going to close out this portion of the agenda with some of the details on the current status of the AHI PPS and that implementation plan. So to begin with, New York's State Health Innovation Plan, or SHIP, it was developed in 2013. You see the elements of it here. I know many of you are familiar with it. Just to kind of get us all on the same page with jargon, the SHIP is the plan. It was developed in 2013 after the state received an award called a Model Design Award from CMMI, the Centers for Medicare and Medicaid Innovation. So the SHIP was really the state's deliverable for that design award. And it paved the way for New York to apply for a model testing award. The model testing award has been made in the amount of $99 million. So those are the dollars to test the model. That's also known as the State Innovation Model, or SIM. Looked at Bob's our SIM expert. I looked at him to go, yes, Colleen, you got the jargon right. Okay, so the SHIP is really a roadmap to coordinate and integrate all payers and all providers to better align incentives and resources to promote systemic reform. That's a mouthful. I mean, I think the thing to remember is that the SHIP is New York's roadmap. And this roadmap is applicable to all payers and all providers, not just Medicaid, not just primary care, not just hospitals. In order to deliver on that triple aim and to stand up a real high quality healthcare system in New York, we need to focus on these 5 pillars. The 5 pillars: access to care without disparities, integrated care models, transparency in cost and quality, transparency both to consumers and to providers, paying for value, not volume, and promoting population health, including screening and prevention and making better linkages between primary care, public health, and community-based supports. I think of these enablers at the bottom as the infrastructure elements that New York is committed to building because they underlie all of the pillars. So we need workforce with both the capacity and skills to meet the needs of changing models and systems of care. Health information technology, of course, is crucial. HIT encompasses data, connectivity. Someone earlier was asking me about RIOS. Data, connectivity, analytics, and reporting capabilities. Those are all needed to support clinical integration, to support new payment models, and really to have that information available so that we can execute on continuous improvement and rapid cycle innovation. As an enabler, performance measurement and evaluation on this slide refers to New York's efforts to evaluate the plan itself, including self-evaluation and independent evaluation. So I think clearly you can see that this SHIP roadmap was the driver behind the design of the DSRIP initiative. Similarly, I think it's evident how that SHIP roadmap informed the development of the state's FIP, the Population Health Improvement Program funding stream. You see a few words about it here. You know, people say to me, you know, they all have the same goal. All these different programs have the same goals, and they all sound alike. They're all guided by the roadmap. So they're all aligned. But you know, as we move forward with DSRIP in our region, it's very important not to allow DSRIP or the PPS itself to become siloed. The PPS, the Adirondack Medical Home, and the ACOs in our region, one of which is shown here, the Adirondack's ACO, are all pursuing the same goals. Long before DSRIP, the medical home sought to improve patient experience and quality of care, as does the Adirondack's ACO. The medical home is an all-payer effort with some 100,000 attributed lives across all payers. Adirondack's ACO participating in the Medicare Shared Savings Program with 25,000 attributed Medicare beneficiaries. And the PPS attribution includes some 94,000 Medicaid beneficiaries and 50,000 uninsured. In addition to these efforts, there are many local efforts with similar goals. So back to the pillars for just a second. The PPS, the ACO, the medical home are all in need of the same enablers and the same or very similar infrastructure to deliver on the triple aim. Effectively managing the health of the population is a goal for all of us, and it requires information and communications infrastructure, clinical management, financial and risk management, and network development, physician alignment. These competencies or capabilities exist to varying degrees of maturity throughout our region, so there's no need to build them all from the ground up. AHI is proceeding carefully to leverage the DSRIP opportunity that's in front of us to the best benefit of our region. And any investments in infrastructure, competencies, capabilities will be carefully planned to be sustainable beyond DSRIP. So that being said, tick-tock, tick-tock, the clock is ticking. There is a very real sense of urgency to achieve the milestones of the PPS at the pace that has been established by the state. The tension between careful long-term planning and the immediacy of the state's timeline is something that the PPSs are, it's a constant source of conversation among the PPSs. No matter how you look at it, we have the clock in front of us. So I just want to reinforce that our role at AHI in health systems transformation in the North Country is very much to balance the immediate needs of this program and this opportunity with a rational and deliberate approach that works to establish a well-coordinated infrastructure for long-term health of the population. So that was the context. That was a lot of the forest. I'm going to shift gears and talk a little bit about some state-level DSRIP developments. If we look back to that letter of intent that we worked on back in, it seems like I always want to say 2013, but it was 2014. It's only been about 15 months. It feels longer to a lot of us. But it was in the spring of 2014 that AHI submitted a letter of intent, as did about 50 other organizations across New York State. Those letters of intent resulted in project design grant awards to 40-some organizations. Since that time, there's been consolidation. So that would be my take on what's happened in PPSs across New York. Consolidation. We see 25 PPSs in place today. There are a variety of governance models. That model that Kathy described, collaborative contracting, does appear to be the predominant approach at this time. We have close working relationships with other PPSs, so I just wanted you to be familiar with their names. There is the North Country Initiative, which is a PPS that the lead entity is Samaritan, largely executed by and managed by Fort Drum Regional Health Planning Organization. So the North Country Initiative, one of our partners. The Alliance for Better Healthcare, that is the name for the PPS that has been established by Ellis and St. Peter's. And Albany Med, they might have a new name too. I'm looking at, Albany Med has a PPS. I think they may have given it another, they haven't renamed? Rachel says no. So, so these are the PPSs that we work with frequently. When I say frequently, we've spent many hours together, especially over the course of the summer. Bob and I worked with two of these PPSs, Albany Med and the Alliance, on a 12-week-long a 12-week-long session to do a scenario-based approach to identifying the business capabilities and the IT structures necessary to support the PPS goals. That was an endeavor that the state made available to us through their support team, through KPMG. And we have some informal kind of phone calls, meetings, weekly efforts. So we're looking to make sure that if there's anything we can do together that makes sense to do on an even bigger basis than within our region, that we do that collectively. The Capital Restructuring Financing Program. The news for most of you is that I don't have any news. I'm sorry. I get asked a lot. We get asked a lot. What are you hearing about CRFP? For those of you who haven't applied, you might not. This is more for you. The program, Capital Restructuring Financing Program, it's a capital stream made available by New York State. Healthcare organizations apply directly to New York State for that capital. New York makes the awards. PPSs were inserted into that process last year when we were asked, or earlier this year, when PPSs were asked to basically gather up all of the applications for capital from all their PPS partner organizations and prioritize them. So steering committee went through a prioritization exercise. Those that resulted in rankings, we are not aware of how heavily those rankings will weigh in decisions regarding those applications. It's the rankings that PPS made, or a piece of information that the state will that we're told the state will take into account in their award process. So we did do a thoughtful approach to the rankings. We have no information about award notices other than what we were told back in June, which was that given that the CRFP funding period begins October 1st, there would be award notices by October 1st. So there are no award notices, and that's where we stand with CRFP. There were some issues that some of you as applicants are aware of, some glitches in the actual application process that resulted in a reopening. So in August, the opportunity to apply reopened. If an application had been previously disqualified for some technicalities in the grants gateway, those applicants could go ahead and submit. New applications were also allowed, but we did not receive any new applications. It was just that same batch. So we had no changes in our rankings in any form. Capital, of course, is vital to several of our projects, not just to Medical Village. I know I frequently talk about the capital in relation to Medical Village. There are capital needs across a variety of projects, so we are very much anxiously awaiting those award notices. So another state level development, the value-based payment roadmap. This was a deliverable that New York State had to produce under their waiver agreement with CMS. The value-based payment roadmap was approved by CMS in July of this year. It'll be updated, revised on an annual basis. And in order to assist in the implementation of the value-based payment roadmap, the state has formed several subcommittees, and you see a list of those committees here. In fact, one of those committees, I think the Advocacy and Engagement Committee, was an important committee that assisted with the development of the opt-out process. So, opt-out. I'm going to slow down just for a minute on this portion of the agenda and point you to some copies that are in your packets. So the opt-out, there is an opt-out letter and an opt-out form in your packet, in the left-hand pocket. So I heard the shuffling has settled down, so I think people found them, are taking a look. The opt-out process is being handled at the state level. So the PPS itself does not have to manage the opt-out process. The purpose of the opt-out process is to provide Medicaid beneficiaries with the opportunity to opt out of data sharing. So in order to, what that means is, in order to implement the goals of in order to implement the implementation plan, the PPS, we need access to information, to claims-based information about Medicaid beneficiaries. And that is, of course, protected health information. It belongs to the individual, has rights regarding their PHI. So the state worked, again, with some committees and advocacy and engagement advisors on how to design and implement a process for notifying Medicaid beneficiaries about DSRIP, about the Delivery System Reform Initiative, and giving them an opportunity to opt out of data sharing. So so there's a gigantic mass mailing that's going to take place in November in order to get information out to Medicaid beneficiaries so that they have the opportunity to raise their hand and say, you know what, pull me out of the data sharing component. It's really about data sharing. There's no way, you think of it this way, when you're doing health systems, when you're doing redesign and implementing new models of care, you can't opt out of taking part in the program unless you're opting out of getting health care. So there's not a way to say I'm not affected by DSRIP or I'm not part of DSRIP, but you can opt out of having your data, shared. So that's what that part is about. We were really pleased that the state stood up and said that they would take care of the opt-out process. That's a huge endeavor. My understanding is that we'll periodically be receiving, once we receive our file of PHI on our attributed lives, we'll periodically get refreshes as opt-outs get received, because people will be able to opt out at any point in time. It's not like you have to opt out right now and you can't opt out later. So there'll be kind of continuous refreshes as responses come in on the opt-out. I really took the effort to make sure you had the actual letter in your packet, partly because our experience under Health Home was that when the state does a big mass mailing to Medicaid patients, people have questions. And who are they going to ask? They're going to ask their healthcare provider. They're going to come into the office with a letter and say, what the heck is this about? I don't understand. Am I still covered? Do I still have benefits? What's the impact on me and my care? So I wanted to give you the actual letter. Should you need anything, if there's anything else we can do at AHI to support getting that information to practices, to clinics, to settings where Medicaid beneficiaries may be asking questions about it, we're happy to do that. There is, of course, a phone number, where they're encouraged to talk to the state directly with questions, but we really want to do our best to help people understand what the letter's all about. So here's another piece of information at the state level. Networks, performing provider system networks are reopening. What that means is that the network that was put in place, we were required to establish that back in November of 2014. The network is reopening. The way they describe it is the performance network is reopening. So what does that mean? Well, what it means is the network that we established back in November, December of 2014, that network was the source information to determine attribution for purposes of valuation. So the network was valued based on the lives attributed to the network as it was defined at that point in time in late 2014. The network's reopening any additions in no way affect our valuation. So the valuation is done. The attribution for valuation, the value has been set. That being said, there's, of course, movement in a network over time, and the state is going to accommodate additions to networks, and that drives what we call performance attribution. So if we have someone new, it doesn't affect our scoring and our value, but the lives attributed as they change because of that new provider will affect how we're measured and will affect our performance numbers. So those lives will be included there. So for us, really, in this region, we don't expect any major additions. I don't know if we'll have any additions. We have to take a look at this unaffiliated provider list. So the department looks at all those networks as they've been defined with NPIs and Medicaid identifiers and says, are there any providers in New York State that aren't attributed to that aren't tied to any PPS? And then they produce that list. That's the unaffiliated provider list. We did get that list. I want to say it came late last week. We're looking into it, trying to see what's there. How can we figure out if there's anyone on the list that's in our region? We'll see if there's. We don't expect. We've missed very many. So we're actually rather pleased that that the vast majority of the providers in our service area have, in fact, already become affiliated with the PPS. Speed and scale. Anyone who's been involved since the beginning, this piece of jargon is familiar to you, speed and scale. And for those of you that aren't, I'm not going to get real deep into the speed and scale weeds. But what they mean, speed is the pace at which we've committed that our providers will meet the project requirements. So we looked at all those requirements. DOH said, how quickly are all your providers going to hit these requirements? In fact, many of you filled out templates last year. We got information from you. We looked at what you projected you thought you could meet those requirements at, and then we hedged our bets and said, we knew we would score better the faster we said we were going to get there, but we said, you know what, let's not overcommit and underperform. So we tried to push those out to what we thought was a reasonable limit that would still get us a decent score. Scale refers to the number of actively engaged patients for the projects over time. Similarly, we took a similar approach. So the speed and scale commitments were part of the scoring. We made those commitments in January of this year. The scoring on that plan ultimately factored into the valuation methodology. So what's the total potential value that the PPS could achieve? A lot of issues with speed and scale. The speed and scale issues had to do with the way that the guidance on speed and scale was rolled out. Our PPS and others had some serious concerns that we voiced to the state. And recently, DOH has announced some changes to the speed and scale targets. So initially, we believed that you would need to meet 100% of your commitment in order to get your check box that you achieved that to drive payment. There's been some scale back on that. I think I want to say 80%, 85% of commitments instead of 100%. It's one of these issues where it clearly doesn't benefit the state if PPSs fail to meet their goals, because there was a lot of confusion and issues when these were set. But because those commitments played so heavily in the application scoring process and the subsequent valuation, they stand. I think we'll just continue to have that dialogue with other PPSs and with DOH on speed and scale over time. So speaking of scoring, one more piece of news. There's a panel called the Project Approval and Oversight Panel, the PAOP. The PAOP is a group that DOH was required by CMS to establish. It's a group that reviews the work of the independent assessor and advises the Commissioner of Health on whether to accept, reject, or modify the recommendations made by the independent assessor. I want to say it was February of this year that Kathy presented to the, was it February? To the PAOP. At that point in time, I'm sorry, I don't think it was in February. It was so earlier this year. All the PPSs were invited to present to the PAOP. At that point in time, the independent assessor had reviewed our project plan application, had scored it, and in order for the Commissioner of Health to determine whether that was in fact scoring that he was willing to accept, the panel reviewed, quizzed, made some really interesting comments, and as a result of that process, the Commissioner followed through on the panel's recommendations to establish the value of the projects. So this PAOP meets, I want to say, twice a year. So it's meeting in November, and we'll be presenting in front of that panel once again. So again, they're really advisors, and they're advisors that'll be in place at the state level to our Commissioner of Health for the entire 5-year duration of DSRIP. I know you can't read those names, or maybe you can if your eyes are better than mine, but again, these slides will be posted after. I thought some of you might be interested in who's on the panel. These are the voting members of the PAOP. Taking a look back for just a moment, earlier in the fall, there was the first annual statewide PPS Learning Symposium. That was a 2-day event, and we had 10 to 12 seats available to our PPS, so the PPS leadership from AHI attended, and several of our partners joined us. We were very pleased to have public health with us, Dr. Irina Gelman from Fulton County, Linda Beers from Essex, Tracy Mills of Glens Falls Hospital took part, Sue Hodgson and George Grillo from St. Lawrence Health System, Canton Potsdam Hospital were there at the event with us, as was Dr. Tucker Slingerland of Hudson Headwaters Health Network. Really kind of nice overview of the state's efforts under DSRIP. The materials are available. They're not restricted to the PPS itself. Any of our partners can take a look if you want to see some of the what happened at that meeting if you have an interest. I just want to give a plug for it because down the road we'll have the opportunity to bring partners again to next time they have a learning symposium. So I would encourage you to talk to Linda, Sue, Tucker, Tracy, ask them about their experiences there those 2 days, how they felt it was in terms of use of their time. I think you'll find that they'd recommend attending if you can do so in the future. Of note at that event, AHI the AHI PPS was asked to take part in a panel on integrated delivery systems, and we were pleased that Dr. Slingerland could be part of that panel.